Hello, everyone can see this talk was for next Friday. Dr. Nakanti asked me if I can give the presentation because he was in the EP lab. I gave this talk last year, so I was updating that. So there are some new information for those of you who have not heard this talk before. So you told me to do which one is that? Oh, okay.
So forward and backward.
Okay, and for
And the laser pointer is the back here.
oh, the laser, that's what I need because okay. So first I want to make sure, what am I doing wrong with this one? Okay.
Oops.
This one bigger.
So that's backward.
Okay.
That's
And the
forward.
laser, I need just a laser, but I can do
Just the
this one. Okay,
Yeah,
thank
thank
you. Okay, yeah. Let me see if I. So I want you to really start paying attention.
if you can hold it.
Where to go with this
Physics.
one?
No, actually, it's this button right
Oh,
here.
this
Goes
I
down.
got.
Yeah.
Okay, I got it. So, why a cardiologist is interested in diabetes? If you have seen this paper, this one came in January 2013 in Circulation. Please see the cost of direct and indirect we spend in the U.S. for cardiovascular, taking care of cardiovascular disease. This is in billion, $312 billion. So if that's the case, I want to show you, are we doing something good? I think in cardiovascular we are doing something good. I would show you diminished morbidity, mortality, but unfortunately the diabetes mortality continue to increase. The obesity, the hyperglycemia continue to increase. So when you take your board, going to be significant number of questions. They want to make sure the internists, they know about the problem, particularly in the US. And 90 to 95% of patients with diabetes, obviously they have type 2 diabetes, and the problem predominantly is insulin resistance. So indigenous people of North America and Australia, they have 20 to 30% incidence of diabetes. Please compare with Africa, really 3.1%. The scientists predict by 2030, so 17 years from now, the three places which we see significant increase in incidence of diabetes, number one would be India, followed by Southeast Asia, then the Middle East. The reason economy is improving, obesity going to increase, and by increasing obesity, diabetes going to follow that. This is the one you really need to know. Those patients with diabetes treated and controlled only would be 12.3%. So we really are doing a poor job. And those they have diabetes treated but and controlled 25%. So those treated and with good control and also suboptimal control, again going to be a small part of those really percentage of patients with diabetes. So you can see 36% we have not made a diagnosis, patient know that, but there are patients, 26%, they know they have diabetes, but they are not taking. So what happened with mortality in cardiovascular disease in the US? You can see continue to diminish, but look at the diabetes mortality. This is really easy to question you on board. So cardiovascular disease mortality in US diminishing, but diabetes mortality is increasing. Again, look at the other cancer, basically flat. but diabetes mortality continue to increase. That's the reason there is emphasis to make sure the future internists, they know about the problem. And again, I want to show you in man and woman, as the BMI increases, the incidence of diabetes would increase. So that's the main. Again, this was published a month ago. A year ago, this one. You can see again that obesity in the US in man and woman continue to increase. Again, showing you relationship between BMI and cardiovascular disease mortalities. As the BMI increases, the cardiovascular mortality is increasing. So I'm repeating that. I want to make sure you get the message. The problem is what is increasing obesity and hyperglycemia, and we need to do a better job. Now, metabolic syndrome, again, there are going to be some questions on that. If patient has 3 of these 5 elements, would be classified as having metabolic syndrome. So obviously it would be abdominal obesity, hypertension, dyslipidemia, triglyceride more than 150, or HDL less than 40 in man and less than 50% in woman, and hyperglycemia. So if we look at really metabolic syndrome elements, the problem we have in the US, obesity continue to increase and hyperglycemia continue to increase. And this is the one was published last month in JACC. The trend in the US, again, you can look at race and age, but the problem is really that obesity continue to increase and hyperglycemia. Now, obviously, we have done a better job controlling blood pressure. We have good number of medicine to diminish the triglyceride, and also the problem with HDL also is improving. So the 2 problems continue to really not address would be obesity and hyperglycemia. There is obviously significant interrelationship in these elements of metabolic syndrome, which would result in cardiovascular disease. Basically, the 3 things you need to know: these patients, they have endothelial dysfunction, inflammation, and have procoagulation. So these, again, it's easy to test on you on that one. So the endothelial dysfunction that we see in patients with diabetes would be decreased vasodilatation, increased vasoconstriction, and increased atherogenic, impaired arterial remodeling, and increased arterial stiffness. They could ask you in different way, but I would show you some more slides, so we would emphasize this one. So the clinical role of hyperglycemia would be really vascular injury. When we look at some of the studies from the past, you can see the subclinical cardiovascular disease would increase as glucose metabolism impairment worsens. So if you look at clinical and subclinical cardiovascular disease compared to normal impaired glucose patients, they have higher than when patients has diabetes. They would really this problem would increase. So in a healthy persons, we have all of these protective factors. The problem with patients with diabetes, these would be suppressed, and harmful substances would increase. They are not going to test you as long as you understand the problem is basically autoinflammation in patients with type 2 diabetes. The cardiovascular complications we see: coronary artery disease, myocardial infarction, cardiac death, left ventricular dysfunction, stroke, peripheral vascular disease. Basically, today we would talk about coronary artery disease. What this slide shows, this one was PET imaging using adenosine or dipyridamole, and look at the coronary vasodilatation. So if you have insulin sensitive, then the patient with insulin resistant, you can see there is some impairment, but statistically is not significant. We see significant problem with vasodilatation in patients with diabetes. Then when they have diabetes and hypertension, that vasodilatory response worsens. So patients with diabetes, they have increased incidence of coronary artery disease, more extensive disease on angiography, and worse prognosis than non-diabetic CAD. Again, I show you slides with this study is from what they call that East-West from Finland. This is relatively old study, but they showed 7 years of incidence of fatal and non-fatal MI. Here you can see the first MI in those they do not have diabetes and those they have diabetes. Please note 6-7-fold increase of first incidence of MI in those patients they have diabetes. The incidence of recurrent MI again is much higher in patients they have diabetes, almost 3-fold. Now, if you pay attention, the first MI in patients with diabetes and recurrent MI in those they do not have diabetes and they have a second MI. So the rate almost is equal. That's the reason we as cardiologists, when we have a patient, we would say, this patient already, you need to manage the patient as already has coronary artery disease. That's where we got the concept. If we look at United Kingdom prospective diabetes studies and look at the CAD risk factor stepwise really selection, in this study, the high LDL was #1 problem, followed by low HDL, followed by increased hemoglobin A1C, then was increase in blood pressure, then smoking. So the same study you can see as age increases, we know patient they would have coronary artery disease. With increased LDL, the higher the LDL, the higher the incidence of coronary artery disease. The lower the HDL, again, the higher the incidence of coronary artery disease. Again, increased hemoglobin A1C, increased incidence of CAD, increased systolic blood pressure follows the higher coronary artery disease, and smoking. So that we as cardiologists have started paying attention to really HDL cholesterol. If you look at some of the studies and you talk to some of the physicians, they give you the impression really treating or improving the HDL is not going to show you, at least consistently in different studies, you have not seen improvement in morbidity and mortality. The reason, because we do not have good information, have to test the function of the HDL. In the near future, we would have a test. There are few manufacturers or pharmaceutical manufacturers working on to look at the HDL function. So not only the quantity is important, the quality also is important. So I have an example to show you here. See, so we really need to have HDL which would function, not HDL which would not, or there is dysfunction of HDL. At this time, really, we don't have a good way to test that, but the work is in progress. I just want to show you again from United Kingdom prospective diabetes studies, higher hemoglobin A1C, you can read the number, higher incidence of coronary artery disease. This is an old slide. Some of you may know that as Mr. Fit study. Shows again these cholesterol and cardiovascular mortality. When you look at the patient that they do not have diabetes compared to those patients they have diabetes, you can see again threefold increase in coronary artery disease problem. Now, before this study, Paris prospective study, we did not have the information to say increased triglyceride would increase morbidity, mortality. After this study, then obviously the cardiology community start paying attention to triglyceride. So now we know triglyceride above 150 would increase the morbidity and mortality, and you saw that also in metabolic syndrome is one of those 5 elements. Again, I want to show you the impaired in glucose really function. The worse the glucose function, the higher all-cause mortality. The same thing for cardiovascular mortality. Now, this is an Australian study, again, looking at all-cause mortality. Please note, again, here you have normal glucose tolerance, impaired fasting glucose. So impaired glucose tolerance, those they have diabetes, but they don't know, and those they are known diabetes. So the worse the glucose metabolism, the higher all-cause mortality. The same thing would follow for cardiovascular mortality. Again, I want to show you the difference between fasting glucose of 100 compared with 110. The higher the fasting glucose, again, would be the higher cardiovascular events. Let's now get to the blood pressure. This study again comes from United Kingdom prospective diabetes studies. They look at the controlling of blood pressure. So these patients, they had a baseline of blood pressure 160/94, finishing with 154/87. The tight control when they had dropped the blood pressure, really systolic 10 and diastolic 5. Let's look at the outcome of this study. You can see any diabetes related endpoint really diminish. Diabetes related death diminished significantly. Now, the myocardial infarction diminished 21%, but this was not statistically significant. Heart failure diminished significantly, stroke, and microvascular disease. So please, when you have a patient, by just dropping the blood pressure systolic 10 and diastolic 5, you can really help those patients significantly. This is hypertension optimal treatment. Again, looking at diastolic pressure of 90 versus 85/80. Please note the major cardiovascular events diminish when you drop the diastolic pressure to 80 or less, 51%. And cardiovascular mortality diminished 67% when diastolic pressure dropped to 80 or less. The effects of risk factor on cardiovascular mortality. The problem with these risk factors, they have additive effect. You can look at one risk factor here. They look at elevated cholesterol, blood pressure, and tobacco. So if you have one risk factor, then you add the second one, it's really more additive effect, and then obviously 3. So we need to really diminish those risk factors significantly. Now, the frequency of ulcerated plaque and thrombus, unfortunately, is much higher in diabetes. These are the patients that came to ED and they did angioscopy, and they saw more ulceration and more thrombus in patients that they have diabetes. That's the reason we say when a patient with diabetes have MI, that's again easy to question you, they would have more myocardium or myocardial damage. They would have higher mortality. Again, before I go, I want to the next subject, I want to show you again the main problem with diabetes, obviously type 2, is the obesity, male and female. This study looked at a prolonged caloric restriction in obese patients with type 2 diabetes, and they followed these patients for 16 weeks. Look at the impressive results. Obviously, the BMI diminished significantly in 16 weeks. Look at the adipose tissue, diminished significantly. The same thing you can see with fat in plasma and myocardium, significantly diminished after 16 weeks. You can see significant diminution in LV mass and improvement in left ventricular diastolic function. Now, next topic would be tobacco. Obviously, you have heard in Eastern North Carolina significantly, so I would not go over that. But more than 1 in every 10 deaths in cardiovascular death is attributed to smoking. And active smoking is associated with increased risk of type 2 diabetes. Here we have several studies, all of them supporting that. So as a cardiologist now, we really look at non-HDL cholesterol. We have learned that recently it's a better measure than LDL cholesterol for identifying patients at high risk who have multiple risk factors. You don't need to order a new test. There is no expense. You just need to really deduct the HDL from total cholesterol if triglyceride is less than 500. So basically, non-HDL cholesterol is looking at atherogenic lipoproteins. Very easy to do that. So in the future, I'd like you to pay more attention to non-HDL cholesterol. So very easy. Look at the cholesterol minus HDL. That would be non-HDL-C. ACC recommends in patients with coronary artery disease, you drop non-HDL cholesterol to less than 100. In diabetes, with one other risk, non-HDL less than 130. Now, this is the guideline from Diabetes Association in diabetes care. So hemoglobin A1C should be less than 7. Blood pressure, they changed that. That used to be 130/80. But in some patients, particularly those they have other risk factors, you really need to drop the pressure more, and they indicate that in their recommendations. They recommend LDL cholesterol to be less than 100. Again, those they have risk factor, they recommend you drop it below 70. So again, ADA recommendation in patients with cardiovascular disease, you need to use ACE inhibitors. Aspirin, we will talk a little bit more about aspirin, and the statin therapy to reduce cardiovascular disease. So these are really, you have to know them. There are going to be multiple questions on board. So again, this is a recent change in 2013. American Diabetes Association changed the recommendation using aspirin for low cardiovascular risk. They are not recommending that, and the reason they state because of there is significant risk of bleeding in these patients. So in actually Diabetes Care 2010, they really did not have that, and they were recommending for all patients. But in 2013, and Tim is here. Tim, last time I gave a talk, he pointed out to me and sent me, and thank you, the recent recommendations. So in patients with prior MI, you need to use beta blockers at least for 2 years after the MI. Again, ADA recommends metformin to be used in patients with stable CHF if renal function is normal. But obviously you should avoid metformin in those patients they have CHF. What I like to show you here, when metformin is being added to the regimen compared with lifestyle, you can see actually metformin is effective, but lifestyle, that's something we forget. We do add metformin, but the lifestyle, you need to really take your time, talk to the patients to increase their exercise and their physical activity. This is a British study. But what they did, they look at retrospectively at those patients. They were treated with different medications for diabetes. What they found, all-cause mortality diminished significantly in those they received pioglitazone and versus metformin. The same thing was for myocardial infarction. At the end of the talk, I have put a slide and talking about the relatively recent recommendation of ACC and American Heart, because we are not recommending any more TZD drugs to diminish morbidity. Although I'd like you to know there are some information, but recently the recommendations have really changed. So low dose of aspirin in type 2 diabetes with no prior history of cardiovascular disease reduced the cardiovascular and all-cause mortality more than 50% in primary prevention setting. As I told you recently, they changed that for low risk. They do not recommend that. And in this study, most pronounced effect was in males and patient 65 or higher. Now, by this time, you know the angiotensin and ARBs, so ACE and ARBs are very, very effective. I just want to show you several studies, and all of these studies indicate ACE inhibitor and ARBs should be considered in patients with diabetes. And again, this slide shows prevention of diabetes by ARBs. Almost all of them are positive. So ACE inhibitors or ARBs should be considered in pre-diabetic conditions in the following conditions. This is really ACC, American Heart recommendation. Those they have metabolic syndrome, those they have hypertension, impaired fasting glucose, family history of diabetes, obesity, CHF, and coronary artery disease. Again, I want to show you changes in high sensitivity CRP. Pioglitazone really diminishes that. Again, the statin diminishes that, but when you combine both, but as I told you recently, the recommendation because of complications with TZD has changed. The reason, because pioglitazone and statin, they have anti-inflammatory effect. I'm just going to show you this slide from TZD, benefit of TZD. These patients are patients, they had prior MI, they have diabetes, and they look at really recurrent MI. So these are really the sickest of the sick. So patients with diabetes and they have coronary artery disease. I want to show you the fatal and non-fatal MI diminish 19%. But again, at the end, I will tell you the recent recommendation has changed. That's what you need to really know for your board exam. So drugs that impair glucose homeostasis would be thiazide diuretics, niacin, and beta-adrenergic blockers. So anytime you use them, you want to make sure the benefit is more than harm. And the drugs, they have beneficial effect, ACE inhibitor and ARBs. Now, calcium channel blocker, they have neutral effect. So the other area they would test you doing a stress test prior to exercise training in patients with diabetes. So these patients should have a stress test. Those they have CAD and have had no stress for the past 2 years, they have chest discomfort or dyspnea, because that could be a sign of ischemia in patients with diabetes. They have peripheral vascular disease, they have CVA, ECG evidence of infarction or ischemia. This thing I like you to know that, because when you look at some of the textbook, they have a lot of information. Actually, a few years ago, we thought we need to screen patients with diabetes for silent ischemia. And that's the reason I'm going to show you that study. So the question, does screening asymptomatic diabetes patient reduce cardiovascular event? Because this is most likely would be on the board question. So this study, diet study, they look at cardiac outcome after screening for asymptomatic coronary artery disease in patients with diabetes. These were completely asymptomatic. ECG was completely normal. I'm just going to show you the result. So as I mentioned, truly asymptomatic normal ECG. They found silent ischemia in 25%, but the severe ischemia was 6%. That's the reason really revascularization in diet study did not show any benefit. So the recommendation after that diet study is close follow-up patients with diabetes and asymptomatic, primary prevention, aspirin, statin, ACE inhibitor, and appropriately timed diagnostic procedure. That means patients with diabetes, if they do not have symptoms, you do not need to do a stress test. Now again, one of the areas they want you as internists to know, that they may give you a picture like that. This is calcium scoring. This is just doing chest CT. Contrast has not been used, so just very low dose radiation. This is the aorta. This is the left main LAD circumflex. You don't see any calcium. This one you see minimal to mild calcium. Look at this patient, has significant calcium in left main, LAD, ramus, and circumflex. So the question they can ask you, which of one of these patients with diabetes would have good prognosis, which would have worse prognosis? So obviously the good prognosis when there is no calcium. And that's also true in general population. When you have significant calcium, it's true in diabetes and also general population. They have higher risk of cardiovascular event. So we see the progression of calcium in coronaries in those they have hyperglycemia and they have significant calcium at baseline. So those are the ones they would have really worse progression. So the emphasis is really control the hyperglycemia. This study look at again calcium in the coronaries in patients with diabetes. Please note patients with diabetes with no or minimal calcium compared to those they had significant calcium in the coronaries. As calcium increases in the coronaries, these patients they had higher cardiac event. So sometimes you could consider doing non-contrast what we call a calcium score. We do that at imaging center. We just really restrict the radiation to the cardiac, and basically if you live in North Carolina, you receive the background radiation is 3 to 3.5 millisievert. If you live in Denver, the background radiation is 10 to 12 millisievert. We give almost 1 millisievert. That would be equal to living in Denver for 4 weeks or living in North Carolina for 3-4 months. So low dose radiation with no contrast. So sometimes you could consider, and by the way, the third parties, they do not cover that, but we have dropped the charges $50. That's for technical and professional reading of that. So sometimes you could consider. Those people I get mostly are physicians so far. So we have tried to, the two states that they cover the calcium score is Texas and California. We tried that here. We have not had really success with the economy not going to right direction. There is less likelihood there is going to be approval. But with that, you can get a lot of information. The next question you need to know as internists, when should you consider revascularization? Because in the old days, we believed all patients with coronary artery disease and diabetes 2 vessel or more, they should have revascularization. So that's the reason this study was done, very 2D. These patients, they had type 2 diabetes, they were suitable for revascularization, and they had documented ischemia. Please note there was no survival benefit in revascularization versus medical therapy. So as internists, if you do a superb job controlling those risk factors, really patient would not lose anything. That's the reason they want you to know, to tell your patient, if they have had a CAT for some reason and they have disease, that doesn't mean they have to have surgery or PCI, as long as they don't have significant symptoms and you can control that, because medical therapy really does a good job as revascularization. This is 5 years follow-up. So you need to know that, because they expect, the board expects you to talk to your patient, and you as primary provider need to tell your patient. Again, please note the cardiovascular event also, there was no difference between revascularization and medical therapy. So let's pass this. I want to show you. So obviously this is the intensive medical therapy was associated with less cardiovascular morbidity and mortality in patients with type 2 diabetes than originally we thought, because that was our practice to send everyone for revascularization. Now the next question is, multi-vessel disease, should they have cabbage or should we consider PCI? Again, this study showed cabbage really had beneficial effect in death and myocardial infarction compared with PCI. So let me go over these recommendations from American College of Cardiology and American Heart for TZD, because they expect you again on board to know that, because this one was published 2010 and they want you to know. So the following are keys to patient management: identification and treatment of correctable risk factors, smoking cessation, high quality diet, weight control and exercise. Use of established secondary prevention. Aspirin, we talk about that in patients. Obviously, they do not tolerate aspirin. You could consider other antiplatelet. Lipid lowering, again with statin as the first line therapy, and blood pressure lowering. So early and consistent attention to controlling hyperglycemia while avoiding hypoglycemia. Metformin is generally first-line therapy, particularly in obese patients. And please pay attention to this one. TZD drugs should not be used with an expectation of benefit with respect to ischemic heart disease event. Insufficient data exists to support the choice of pioglitazone over rosiglitazone, because we believe a few years ago pioglitazone was superior to rosiglitazone, and there are, as I show you, one of the one in the sickest of the sick, but obviously we need to go with the guideline. And TZD drugs, they want you to know increase the risk of heart failure and should not be initiated in patients with class 3 and 4 heart failure. Thank you. Let me stop here and let you ask questions, because this is a really topic. They are interested, the board is interested, they are asking for questions on this subject. They want to make sure the internists or we as a community do a better job to prevent the problem with increased number of patients with hyperglycemia and obesity. And when we have a patient with diabetes, we know that that's inflammation, and we use the right medicine to treat the patients. Please.
You have a patient who is already diabetic and is on a TZD and then develops heart failure.
I could not hear you. I'm sorry.
Sorry. You have a patient who is already. I'll come up.
Yeah, please. Yeah, I know. Yeah, go ahead.
So, if you have a patient who is already diabetic and is on a TZD and then they develop heart failure, should you take them off the TZD?
Okay, that's a very good question. Definitely. Definitely I would remove the TZD. That's the first thing you do. Again, we have several studies. Again, don't forget, this is class 3 and 4. So here was not class 1 and 2. Actually, there was a nice study. I used to have that in my talk when I was giving talk to endocrinologists. There was a nice study was done at Cleveland Clinic, and they look at the patients they thought they have been admitted with heart failure due to TZD. So these patients, they got echo, and all of them, they had Swan-Ganz catheter. So they measure left ventricular feeding pressure, PA pressure. The conclusion of that study, those patients would, obviously they were using pioglitazone because that was the drug at the time they thought, or we thought was beneficial. And the problem was volume overload was the problem. So most of these patients, they responded to low dose diuretics. So it does not really diminish the ejection fraction, does not impair the left ventricular diastolic function. What would do would just increase the intravascular volume. But if that's the question, yes, if patient develops heart failure if they are on TZDs. I don't think anyone, I have seen less and less patients receiving TZD, because the other problem with prior glutathione was prostate cancer. You have been hearing probably on TV commercial. Rosy glutathione actually was worse. A couple of years ago when I went on internet, because FDA first recommended not to use that. There was advertisement with different, from different law firms. If you have had a heart attack and you are receiving rosiglitazone, please call us. You don't have to pay money up front. When we get the money, we share it. But so the TZD, I don't think we are using that. We are not recommending that. I think endocrinologists have to start using that with these recommendations.
If there's a patient who's intermediate risk for coronary artery disease, he is diabetic, and we go ahead and get a coronary artery calcium score, it comes out to be like 500.
That's a very good question. Yeah.
So are we stuck? The patient gets apprehensive now. Do I go for a CAT? What should I do?
Excellent.
No
actually, that would actually, I'm glad you mentioned that, because ASNAC, American Society of Nuclear Coronary Radiology, American College of and American Heart, they recommend those who do calcium score above 400. It's one of the indications to do a stress test rather than CAT. So do a stress test would be exercise or pharmacological stress test. In general, publicly, if someone has more than 400, you have the right to do. But again, you as primary care know that I show you the result. The best thing you can do, aggressive medical therapy, because when you know the final result, if patient doesn't have symptoms, if you do a good risk factor modifications, basically the message you get from that test to be very aggressive. Make sure LDL is less than 70, HDL if female less than 50, if male less than 40. Make sure blood pressure is tightly controlled. Obviously, control the glucose, but don't make the patient hypoglycemic. So I use aspirin in that case. Then I think you would be fine. I think, but yes, you could do a stress test. I think. When we talk about asymptomatic patients, there is no good data to support make big interventions such as do PCI or CABG. I think that's the message we are getting. In the old days, we really look at those blockages and we thought they have to be fixed. But really aggressive risk factor modifications really is equal to rehab. That's really the message you can give to your patients. Thank you.